20 years old male patient, known case of diabetes hypertensive for past 25 years, had stroke 2 years back, followed by complete heart block as a pacemaker in situ and residual hemiplegia, posted for TURP, sir.
Okay.
70 years old Srinivasan from Chennai came to hospital with complaints of difficulty in passing urine since 6 months. History of present illness, history of difficulty in initiation of urine after feeling of bladder fullness, history of feeling of incomplete bladder emptying, history of constipation. Since 6 months, sir. History of past illness, patient known case of diabetes and hypertensive since 25 years on regular medication, and known case of CVA for past 2 years with residual hemiplegia for past 2 years and on medications. And also known case of complete heart block. Patient was symptomatic with history of syncope. So patient is on now pacemaker for past 2 years. No further episodes of syncopic attacks. No history of any bronchial asthma, epilepsy, or TB. Treatment history: patient is on OHA and a tablet and for antihypertensives like tablet Amipril, tablet aspirin and a tablet clopidogrel, sir. Personal history: patient not a smoker or alcoholic, consumes mixed diet, normal bowel habits, altered bladder habits. Family history: no significant family history. Treatment history: patient was on treatment of UTI for past 2 months back, treated with antibiotics. Symptoms subsided, but hesitancy persists. Summary: a 70 years old male patient, known case of diabetes, hypertensive for past 25 years, had history of stroke for 2 years back, followed by complete heart block with pacemaker in situ and residual hemiplegia. Now patient posted for TURP, sir. I would like to evaluate further, sir. General examination.
Okay. Before going for that,
Yes, sir.
what are the challenges in this case you have? The case scenario that you have got now, what
Yes,
are
sir.
the challenges you face in this case?
Sir, patient is 70 years old patient, sir. And
So,
geriatric considerations.
all considerations for a geriatric case. Okay.
Yes, sir. And patient is also known hypertensive, diabetic. And since 25 years, so chronic comorbidities, sir.
Okay.
And associated any neuropathy.
So all the other complications of the two chronic diseases, comorbidities, hypertension and diabetes. Okay.
Yes, sir. Yes, sir.
Recently, stroke, heart block.
Yes, sir. Complete heart block.
Complete heart block, stroke.
Patient. Yes, sir.
Residual paralysis is still there.
Yes, sir. And
These are the 5 challenges you are facing in this case. One is geriatric patient, second is chronic hypertensive, chronic diabetic, third is fourth is recent stroke, fifth is heart block, the pacemaker institute. So these are the 5 challenges you have to solve. So with these 5 challenges in mind, what are all the physical examinations and the investigations you want to do for this patient?
General examination, sir.
Okay.
Patient sitting posture, first height, weight, and the BMI will calculate, sir. And any dyspneic or tachypneic I'll observe, sir. Any pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema, and elevated JVP are present or not, and abdominal distension present or not, BP, pulse rate, and all, and airway examination, sir. external airway appearance, any DNS, mouth opening, Malampati score, range of neck movements, and temporomandibular distance and the temporomandibular joint, mobile or not. And further, I would like to examine systemic examination, cardiovascular system, and any murmurs. I'll and after respiratory system, uh, uh, followed by CNS examination, sir.
Okay. Right. What are all the investigations you want to do in this case?
Sir, investigations I would likely to do complete blood count and in that hemoglobin.
Why, what is the importance of complete blood count? Why do you want to do that?
Sir, the TURP case, there is most likely to occur bleeding, sir. Bleeding, sir. Bleeding, high risk of bleeding intraoperatively. So, to know the hemoglobin prior to surgery and to reserve adequate blood so that we can correct hemoglobin intraoperative postoperatively, sir.
Okay.
The UTI and to evaluate the UTI total leukocyte count will see, sir. And will treat accordingly. If a patient having any UTI, will give antibiotics. And next is serum electrolytes, sir. Sodium, potassium, chlorine. If any electrolyte disturbance is there, we'll correct it prior to surgery, sir. Because in DURP case, mostly there will be chance of hyponatremia, sir. So we'll correct priorly, and I'll look out the correlation
Before surgery or after surgery?
during and before after surgery, sir.
During and after surgery. So what is the purpose of doing the electrolyte and sodium before surgery? Is there any use in doing that?
If patient is on any diuretics, there will be loss of.
Okay. Supposing there is no diuretic therapy at all.
Okay, sir.
Then is there any importance of doing sodium, especially for TURP patients? Any formula you can use using sodium?
Yes, sir. We can calculate the volume of water absorbed.
Very good.
Rapidly.
Yes. So
Using
volume
sodium
absorbed can be calculated using the pre-op and intra-op post-op
sodium.
sodium.
Yes.
Okay, that's another important advantage of using pre-op sodium. For that, you have
Yes, sir.
to know the normal sodium level prior to surgery.
Okay, sir.
Then only you can calculate the volume absorbed. Okay.
Okay, yes, sir. And the next coagulation profile, sir. Any bleeding disorders will is there? We have to correct priorly, sir. PTNR, BTCT, bleeding time and clotting time. And patient is on, if patient is on any antiplatelets or anticoagulants, we have to stop it priorly 5 days prior to surgery, sir. And
okay. Do you think this patient may be on antiplatelet agents?
yes, sir. Aspirin and clopid, sir.
Why?
Patient had a history of stroke, sir.
Stroke. Okay. What are the types of strokes?
Hemorrhagic stroke and thrombotic stroke, sir.
Ischemic stroke. Very good. Okay.
Sir.
Which is more common?
Thrombotic stroke, sir.
Thrombotic stroke is more common. Very good. Okay. Right. What is the other major problem in this patient?
Pacemaker is in situ, sir.
Okay.
In situ,
What
sir.
are the things you want to know about the pacemaker?
First, I will in history we'll evaluate the indication of pacemaker, sir, pacemaker institute, and it's interrogation you have to do, sir, prior to surgery about battery life and intrinsic rhythm of the patient and
Okay.
mode and leads placement.
So what do you think, what type of cardiac device, implantable electronic device this patient may be in?
For a complete heart block,
What
artificial
are the types of cardiac implantable electronic devices you know?
permanent pacemaker,
Very good.
artificial implantable electronic device like D,
With the defibrillator.
yes, sir, yes,
And
sir.
third one?
Without defibrillator, sir.
Hmm?
Without the defibrillator,
With the, no, permanent pacemaker does not have a defibrillator.
yes, sir.
That is only for rate and conduction.
Okay, sir.
Whereas AICD
Yes, it is, sir. Artificial
is
implantable
the
cardiac
implantable
device.
cardiac defibrillator. What is the
Yes, sir.
indication for putting that AICD?
Any arrhythmias, potential
Tachyarrhythmias, which are likely to go into ventricular fibrillation or ventricular tachycardia. What is
Okay.
the third type of electronic device that can be implanted?
Cardiac resynchronization therapy devices.
Resynchronization therapy.
Therapy.
What is the importance of that? Why do you want to do the cardiac resynchronization therapy device?
For heart failure patients.
For patients who have low stroke volume or cardiac output.
Yes, sir.
These
Hello, sir. Hello, sir. Sorry, sir. Voice break, sir.
permanent pacemaker, which is mainly used for conduction or increasing the rate.
Yes, sir.
Second one is for controlling the
Arrhythmia.
tachyarrhythmias.
Yes.
Third one is for
For effective
improving the cardiac output. So these are the three types of devices. So which type of device this patient may be having with the complete heart block?
pacemaker, sir.
Hello?
Pacemaker, sir. Pacemaker. Hello, sir. Hello, sir. Hello, sir. Hello, sir.
The speaker. Cardiac electronic devices, implantable electronic devices. This case may be, this patient may be having only a permanent pacemaker because he has a total heart block. Correct?
Yes, sir. Yes, sir.
Okay. So with the patient with the permanent pacemaker, what are all the things that you want to know about? That is the main reason why such cases are given in the examination. Either a scenario or a patient with a pacemaker may be kept in the examination just to find out what are the things that as an anesthetist you should know about the pacemaker's interaction
Yes, sir.
when patient comes for surgery.
Previous symptoms persist. Mode of the pacemaker, the placement of leads, and intrinsic cardiac rhythm, and battery life, uh,
Okay.
magnetic programmability is there or not? Magnetic programmability.
Magnet
Yes, sir. Programmability, sir.
programmer. What is the what magnet? There is nothing called magnetic programmer. There is a magnet and there is a programmer. These are two different things.
Okay,
So
sir.
when will you use a magnet? When will you use a programmer? What is the purpose of using the magnet?
Um, to To change into asynchronous mode, sir.
So patient may be on, first of all, we should know whether the patient is pacemaker dependent or
Yes, sir.
okay.
Yes, sir.
So patient, if is fully dependent, then you should change that from synchronous mode to asynchronous mode. What do you understand by this terminology, synchronous mode and asynchronous mode? If you are not able to answer that,
no, sir.
Dr. Ramu, are you there?
Yes, sir.
What is synchronous mode and what is asynchronous mode? But all the book says, all the webinars or all the videos you watch, everybody says that you have to change from the synchronous mode to asynchronous mode before using or submitting a patient with pacemaker for surgery. What is the what do you understand by that term?
Synchronous mode means a patient will be getting the pacemaker rhythm with according to the patient's heart rate, sir. If there is tachycardia, the patient will be brought down to bradycardia level, or if bradycardia, if any arrhythmia, patient will be brought down to normal rhythm. A synchronous mode means patient will delivering a fixed rate, sir.
Pacemaker
Irrespective of
deliver, patient's heart rate will not have any
influence on the pacemaker
function. That is the meaning of asynchronous mode. Okay. Synchronous mode means a patient's inherent activity. If there is any inherent activity of the patient's heart conduction system or the pacemaker, it will get adjusted to the pacemaker's function. Whereas when you switch it over to asynchronous mode, patient's inherent cardiac conduction activity will not have any influence over the pacemaker function, and pacemaker will deliver a constant rate of generation of current. Okay, that is the meaning. So that patient will all the time get a answer, just like you are in ventilator when you give SIMV, that is synchronized intermittent mandatory ventilation. Whenever patient is not breathing, automatically the machine will give. Like that, asynchronous mode will automatically deliver a current, so that at no time patient will go for bradycardia or asystole. That is the idea of converting the synchronous mode to asynchronous mode. Okay. Whereas when it is a synchronous mode, patient's inherent cardiac activity will be able to inhibit or trigger the pacemaker function, so that when the inherent heart rate goes down, it will stimulate the pacemaker to increase the heart rate. When the patient's heart rate goes up, it will inhibit the heart rate, pacemaker, to reduce its supply. Or when there is a bradycardia, it will trigger and increase the heart rate or this rate discharge from the pacemaker. Okay, that is the meaning of synchronous and asynchronous mode. So it is always safer to switch over to asynchronous mode. And this can be done by applying a magnet over the pacemaker, the generator, which is implanted into the chest of the patient. So by applying this magnet over that area, we can control, change it to asynchronous mode. But can this be done if it is an implantable cardiac defibrillator? Can you use a magnet and do this function?
Yes, sir.
Yes.
Anti-tachycardia, sir.
Anti-tachycardia function only will be
using
require what is called the programmer. Programmer is used mostly only for the implantable cardiac devices or the resynchronization therapy. Okay, so for full pacemaker, we need only a magnet to change it from asynchronous to asynchronous mode. So that point has to be very clearly understood. Okay, right. So all these things, and this TURP, how it is done, what type of surgery it is a endoscopic surgery, correct, isn't it? So,
and yes, sir.
Tissue resected, what do they use to, what instrument do they use to resect the tissues?
Resectoscope, sir.
What type of current or more
Unipolar.
they can use a unipolar or a bipolar loop which delivers a current to coagulate and cut the tissues and remove the tissues. Okay. So which type of polar you should use, unipolar or a bipolar for this surgery?
For this surgery, bipolar is
It is
preferable,
always
sir.
better to use bipolar. So what is the main danger of using this sort of cautery-like thing for surgery in this case? What complication it can produce to the machine or
Electromagnetic interference.
That is the
Yes.
main danger. So we should avoid that electromagnetic interference which can interfere with the function of the pacemaker. That is the idea that we want to keep in mind. So what are all the preventive measures or prophylactic things that you should do to prevent this EMI or electromagnetic interference?
We have to change mode into asynchronous mode, sir.
That is with the machine. But what are all the surgical preventive measures you can do?
Okay. We have to use only bipolar cautery.
Bipolar cautery, very good. Then
If
for
we have
supposing bipolar cautery is not effective and surgeon wants to use monopolar, then what are all the conditions that should be fulfilled to use a monopolar cautery?
if we're using monopolar, we have to use a short burst of
Very
less
good.
than 1 second
Very
and 10
What
minutes.
about the earth plate or the contact plate? See, for monopolar, you need a contact plate or earth plate, isn't it?
Yes, sir.
For bipolar, you don't need that.
Yes,
So
sir.
what about the earth plate? What precautions?
We should not. We have to keep away from the axis of the current passing.
Yes. So it should not be very close to the pacemaker generator. Okay? That is the machine that is actually generating the current. So it should be at least 6 inches or 15 centimeters away from the pacemaker generator, pacemaker generator component. And no wire should cross that area.
Yes, sir.
And in case supposing there is a cardiac arrest intraoperatively, where will you keep the paddles?
Anterior posterior is preferable, sir.
Very good. So it should not cross over or come to the area close to the again pacemaker generator. These are all the points that you have to keep in mind, right?
Okay.
Now with this background, now you want to suppose use the this patient is posted for TURP. So you have done all the basic investigations like, and one more thing about the pacemaker, do you need a X-ray chest before you do the surgery?
Yes, sir. We have to take one chest X-ray to know the placement of pacemaker, sir. Where exact placement?
Electrodes or leads, where exactly they are going. Then any other reason for taking the X-ray?
To compare size of the pacemaker priorly and now.
Okay. Whether it has migrated or not. Okay. Then anything else you can find out? Any other complication could have happened over a period of 2 years with the pacemaker in the position? Any broken leads?
Broken leads.
That also you can find out. Okay. So the reason for taking an X-ray test is to find whether it is a single chamber pacing or dual chamber pacing, whether the electrode leads are all in proper contact, and whether there is any discontinuity or breakage of the electrodes. All these things can be found out by taking an X-ray test. So an X-ray test is also very, very important. Right.
Okay.
So with this knowledge, patient is now posted for TURP tomorrow. I have seen the patient in your given fitness. What are all the instructions you will write?
NPO order, sir.
Very good.
Inform
NPO being a diabetic patient, what is the NPO guidelines? Is it like a normal routine patient for 6 hours of NPO, or you want some other
for liquids
2
hours
given for diabetic patient?
For liquids 2 hours NPO is enough, sir.
Okay.
and we have to withhold OHA prior to surgery, sir.
Okay.
On the day of prior to surgery.
So
And
you should know the medications for diabetes he is taking. That is one of the
yes, sir.
important pre-anesthetic information that you want to know. Okay. Whether
Okay,
the
sir.
patient is taking only OHA or whether he is taking insulin also. If so, what type of insulin? All that questions may be asked in the examination, especially if we are going for a viva. Instead of asking about TURP, they can ask you all about diabetic medications. So if the patient is taking OHA and insulin, how will you
Okay,
advise
sir.
the patient?
We have to withhold the OHA and insulin on the day of surgery.
Don't
On
you
the day
want to know
morning.
what type of insulin he is taking? I told you insulin. That
Yes,
is
sir.
all the information. So you want to know what type of insulin he is taking, whether it is a Mixtard, whether it is a Lantus, whether it is a Actrapid. So that
Yes,
detailed knowledge about the insulin is very important, isn't it?
yes, sir. Yes, sir.
So normally, what do the patients take nowadays?
Mixed
What are
and
the types of insulin you know?
short acting and
Hmm.
long acting, sir.
Short
Intermittent
acting,
acting and long
intermediate
acting.
acting, and long acting.
Long acting.
Hmm.
Yes, sir.
Can you tell me example of long acting?
Uh,
Gludec or Glargine. Okay, 24 hours.
glutaric
Once a day dosage.
Yes, sir.
What is the purpose of once a day dosage insulin?
Sir?
Why do they prefer to give once a day dosage? What is the purpose? How does it act? When you give a Lantus, that is Glargine or Gludec, which acts
To
for
maintain
24 hours, what is the advantage? What does it do?
basal insulin
Basal
level.
production. Excellent. So there are two types of insulin release in the body. One is the basal release, another is a spontaneous release after meal. Every meal there is a increased production of insulin to counteract the glucose load that is taken by the patient. So the Lantus or Glargine or Gludec will only take care of the basal insulin. So you have
Okay.
to give supplemental insulin for the bolus insulin
Bolus.
you have to give for the glucose load that the patient is taking, like breakfast, lunch, and dinner. So
Yes.
two types of insulin will be used. Okay.
Yes,
So all
yes, sir.
this you have to find out and preferably convert all this to what type of insulin. Supposing patient is taking Lantus and mixed at 70-30 twice a day.
Yes, sir.
How will you convert this, or will you accept the patient with this, or will you convert it to some other form of insulin?
Short acting insulins. Night
You have to go
dose
for a short acting insulin. Why?
because that action will continue for one day. No, sir. Patient is on NPO and most risk of hypoglycemia events.
Very good. So short acting easy to titrate. Okay.
Right, it is.
Yes. So that patient, your aim in managing any diabetic patient is to avoid hypoglycemia all the time. Even a little bit of hyperglycemia can be accepted, but never err on the side of hypoglycemia. Okay, that is the major basic safety measure that you have to keep in mind. Okay, so
Okay,
but
sir.
if the patient is on OHA,
Okay, sir.
what are the types of OHA you know of?
Sulfonamides,
Biguanides, sulfonamides,
thiazolidine diones.
urea.
Yes, sir. Biguanides, thiazolidine diones, alpha glucosidase inhibitors, and
What is the current
non-insulin
latest drug that is being commonly used by many diabetologists?
metformins.
Current latest drug. Metformin has been there for a number of years.
Okay, sir.
A recent drug which has come up in the last 5 to 10 years and being common. Initially, there are a lot of adverse reports about that, but now people especially diabetologists and cardiologists prefer to use that because it's supposed to not only control the sugar well, but also remodel the cardiac function and prevent the cardiac complications of long-standing diabetes. What is that drug?
Linagliptin, sir.
Gliptins are DTP, that is dipeptidyl peptidase inhibitor, viragliptin, sitagliptin, all those things.
Yes, sir.
More recent than that, more latest. Have you heard of SGLT2 inhibitors?
Yes, sir.
What is that? Ammo,
Sodium glucose acts on the kidneys, sir. Sodium glucose.
gabaploxacin.
Yes, sir. Yes,
So
sir.
these drugs are supposed to excrete the excess sugar that is there in the blood, in the urine,
Yes, sir.
remove the decrease the plasma level or serum level of glucose. Initially, when they were introduced, what were the complications of this drug, SGLT2 inhibitors?
UTI infections, sir.
UTI, very good. Fungal infection
Other infections.
in
Okay,
the
sir.
peritoneal area. And what type of ketoacidosis it produced? Produce euglycemic ketoacidosis. Normally, when you say ketoacidosis, patients used to have severe hyperglycemia. Blood sugar
Yes,
350, 400, 450 like that. But SGLT2 produces a different type of ketoacidosis where blood sugar will be normal, 180, 200. But
okay.
we have ketones, and that is called euglycemic ketoacidosis.
Sure.
It's another complication of this drug. But nowadays, all these things have been accepted, and it is supposed to have a beneficial effect on the myocardial function. So nowadays, people are writing this drug more and more. So we have to be aware of this drug also. So what is the advice that you will give with regard to supposing a patient is taking SGLT2 also?
Okay, sir.
Available in so many brand names, Farxiga, Udapa, so many names it is available. So if the SGLT2 is being prescribed and he has been taking that, what is your advice? When will you stop it?
One day prior to surgeries.
48 hours. It is
48 hours.
recommended that you should stop it at least 48 hours
48
before
hours.
the surgery and switch over to actrapid or short-acting insulin to control the blood sugar if there is a rise. On the other older drugs like long-acting sulfonylureas like
Yes, sir.
or glibenclamide.
Glutamine, glipizide, glimepiride.
And metformin, what is the risk of giving metformin?
Lactic acidosis.
So metformin also can be stopped one day prior to the surgery. Okay?
Okay,
So
sir.
these are all the advice that you have to give. And if supposing what about the blood sugar values assessment before surgery for a patient with diabetes coming for surgery?
Early morning fasting blood sugar will have to check, sir.
Hmm.
Preferable 180 to 200 on the day of surgery, sir.
Okay. So before starting NPO, blood sugar is 160. Okay. After 3 hours of NPO, patient says he is feeling giddy and there is light sweating. What will you do?
We'll check once more.
You have to check the CPG. CPG, supposing it is 80. So you
Okay.
is it acceptable?
5%.
Chronic diabetic to have a CBG of 80, is it acceptable?
No, sir. I'll infuse 5%
That
dextrose.
is considered as hypoglycemia.
Hypochlorite.
So 80 to 120 if normal is only for normal blood patients. Chronic diabetic patient, even 80 is considered as hypoglycemia. So you have to, what instruction you will give? Supposing you have said NPO 6 hours and you
Okay,
get
sir.
a call after 3 hours of NPO, patient is feeling giddy and we have checked the CBG, blood sugar is 80 milligrams per deciliter. Supposing information you get, what advice you will give to the attending staff?
Hourly monitoring with infusion of 5% dextrose 100 ml per hour.
So you must supplement with intravenous glucose 5% dextrose solution. 75 to 100 ml per hour should be given till the time patient is shifted to theater. Okay. So
Okay.
the pre-NPO blood sugar and intraoperatively, if the patient develops any symptoms of hypoglycemia, immediate CBG, and starting of 5% dextrose is very, very important to prevent the complication of hypoglycemia. Okay, this can happen even in this patient. So that also has to be taken. What about the hypertensive medications? Patient is a long-standing 25 years of hypertension is there.
Yes, sir.
So what are the things that you want to know about the hypertension?
If patient if on any beta blockers, usually this patient doesn't on any beta blockers, sir. If on any beta blockers, we have to be we have to continue on the day of surgery. And patient is on any AC inhibitors or ARV inhibitors, have to be withheld on the day of the surgery, on morning on the day of the surgery.
Very good.
And, patient is on any diuretics, we have to assess his patient's serum electrolytes.
Very good.
And you should not give calcium channel blockers and beta blockers at the same time. It leads to bradycardia, sir.
Very good.
And
Okay, so these are the instructions that you have to give with regard to his hypertensive medications. Okay,
okay,
right,
sir.
right. So if all these things have been followed and patient has come to the OT,
Okay, sir.
how are you going to give anesthesia for the surgery? What is your choice of anesthesia, GA or regional?
I would likely to prefer regional anesthesia, sir. Subarachnoid blocks.
Why regional is preferred for TURP cases?
To detect early signs, symptoms of TURP, sir.
TURP syndrome.
Patient is
Excellent.
having. Yes, sir.
Right. So is there any contraindication for giving a regional in this case?
A patient is on any aspirin and clopidogrel.
Very good.
Yes, sir.
So antiplatelet agents have to be also properly titrated and stopped well in advance. And if there is no altered coagulation profile or INR is normal, you can definitely go ahead with the regional. Okay.
Yes, sir.
So is there any contraindication because he is having a residual hemiplegia for regional?
No, sir.
No. So that is another point. Because patient had a neurological insult earlier, like hemiplegia, and recovered from that.
We have to
That is not a contraindication for central
regional.
neuracil blockade. So it can be safely performed. That has been the dictum that has been done.
Yes, sir.
Is there any contraindication because he has a pacemaker?
No, sir. We have to
No.
be careful for using unipolar cartridge, sir.
Okay. So it is more, no, there's no contraindication for using a central neuraxial blockade because patient is having a pacemaker also. So both these conditions which are mentioned in the case scenario are not contraindications for central neuraxial blockade and they can be safely administered in this patient. Right. What position you want to adopt for giving your neuraxial blockade, subarachnoid block? You want the patient to be sitting or you want the patient to be lying down?
Sitting position, sir.
Sitting position. Why you prefer sitting position?
For level adequate, I have to
What is
use.
the level that you want to achieve? What is the mass supply to this?
Up to T10 is enough, sir. Up to T10 is enough, sir.
Okay. What is the nerve supply to the prostate gland? Sensory supply pain.
Sensory வந்து L1, L2, L3, sir.
Sensory L1, L2, L3.
L2, L3, L4, sir.
It's not sacral. S2, S4, S3, S4 really. Apodental nerve branches and is it not that is the supply? Mostly the sacral nerves.
Yes, sir.
L1, L2, L3 is more of sympathetic.
Okay, sir.
Okay. Pain
Okay.
sensation is mainly from the sacral S2, S3, S4.
Okay, sir.
So why do you want a block up to T10?
If any bladder perforation,
Will always bladder perforation occur, or it is much more another reason for why you want to have a block
bladder,
up to
bladder distension also.
bladder distension. So because they are going to use an irrigating fluid while
Yes.
doing the resection, it will be filling up the bladder. Bladder will get distended. So to block the bladder distension discomfort, it is actually not a pain, but it is a discomfort. So to prevent that bladder distension discomfort, you need a block up to T10. Otherwise, patient will complain of lower abdominal discomfort. But
Okay.
actually, the pain fibers are coming only from the sacral segments of S2, S3, and S4. So in patients who are very critically ill, like a cardiomyopathy patient or patients with very poor hemodynamic stability, you can even block the sacral fibers alone by doing what is called a caudal anesthesia and ask the surgeon not to distend the bladder with too much of irrigating fluid and frequently empty the bladder and to perform the surgery. So that also can be done. Okay.
Okay,
So
sir.
if the examiner asks you why you want to block up to T10, it is mainly to block the
Bladder distension discomfort.
discomfort. Okay, that is the answer that you have to give. Right.
Okay, sir.
So you prefer to give the block. What is the volume that you want to give for achieving a block up to T10? And what drug you want to give?
0.5% heavy bupivacaine, around 2 ml, 1.2 ml is enough, sir.
2.5 ml is enough. Very good. Any additives you want to add to this?
We can add buprenorphine or fentanyl.
Fentanyl also can be added. Why you want to add a additive to this? What is the advantage of adding an additive?
Prolongation, it will increase the duration of drug action.
Okay. But
And
normally, can you do TURP surgery for 3 hours?
no, sir.
Why?
We should not exceed the surgery more than 60 minutes, sir.
Ah.
However,
Why
more
you should
chance,
cut down the surgery to 60 minutes? Why not like other surgeries perform it for 2 hours or 3 hours?
more chance of volume overload, blood pressure.
Fluid absorption or irrigating
Exhaustion.
fluid absorption will be more and that will lead to complications. So that is the way there is a rule of 60.
Yes,
What
sir.
is the rule of 60?
60 grams of prostate is the cutoff point for the surgery, and 60 centimeter height of hydrostatic pressure, 60 minutes for the surgery, sir.
Surgery. Okay. So these are the 360s. Okay. So that is the reason why you want to control the time also. Okay? Very good. So this is the as you are doing the surgery, patient becomes slightly restless. After half an hour of surgery, patient becomes slightly restless. The blood pressure, which has come down from, say, your starting blood pressure was 140/90, it has come down after spinal to 120/80. Now it is again going back to 140/100 and the pulse rate is dropping from 70 to 60.
It indicates
What
volume overload, sir. We have to ask the surgeon to stop the surgery, and we have to take one EKG, and we have to see patient's serum electrolytes, sir, and acidity, pH value.
So in this patient with the pacemaker, what are all the monitors that you want to use for this surgery? Any specific monitoring is required because the patient has a pacemaker?
So intra-arterial BP monitoring, I would likely do.
Intra-arterial BP monitor or something more non-invasive which can give the same information that you want by an intra-arterial monitoring.
ABG, sir.
Non-invasive. ABG is also
Yes,
invasive.
that is.
Arterial is also invasive. My question is, what is the non-invasive method of monitoring?
Patient should be conscious.
Monitor.
Monitoring.
You are
Yeah.
monitoring consciousness is your own observation.
Okay, sir.
Pulse oximetry with a
Pulse.
plethysmographic tracing. That is the answer. Okay. A non-invasive is pulse oximeter with a plethysmographic. Some of the pulse oximeters give only the saturation and the heart rate. There won't be any tracing, isn't it? Small,
Yes, sir.
simple monitors are there nowadays. Very cheap monitors, which have become very popular in your COVID time. For 1,000 rupees, 800 rupees, you are getting finger probe monitors, which don't show any tracing. Whereas when
Okay, sir.
you monitor a patient with a pacemaker, you should always have a plethysmographic tracing pulse oximetry. Why it is important to have this plethysmography?
Volume status, sir. To know the volume status.
Because sometimes ECG also can miss the functional status of the pulse maker. Okay, sometimes there may be a wrong information or a misguiding information from ECG. So pulse oximetry only will tell you whether the pulse is coming up to the periphery by creating the plethysmographic tracing. Okay, so that is the way you monitor the heart function, whether the heart is naturally beating or not, or it is being stimulated to beat. It is far more confirmative by checking the pulse oximetry with the plethysmographic tracing rather than depending on ECG for the heart function. Okay.
Okay, sir.
Right. So patient, you stopped, and then by the time all things are done, patient is throwing a fit. What will you do? You have observed that the patient's BP is going up, heart rate is coming down, you suspect fluid overload, you ask the surgeon to stop. But by the time you tell all these things, patient is throwing a convulsion. What will you do?
We have to secure airway breathing.
Very good. ABC. Excellent. Oxygenation, airway breathing, right? And then?
And anti-epileptic agents like midas, diazepam, pill, we have to start, sir. And
so is it one of the manifestations of TURP syndrome?
Yes, sir.
Seizure?
Yes, sir.
Yes. So how do you prove that it is a manifestation of TURP syndrome?
We have to take any ABG, sir. Any hyponatremia with elevated BP.
Nowadays, ABG itself gives you sometimes the electrolyte values also. So the ABG should, you must know that the ABG machine will also give the electrolytes. Otherwise, you must separately send the bed for electrolytes and get the sodium level assessed. Okay?
Yes, sir. Yes,
so supposing sodium level is 114, 114.
Yes, sir.
What will you do?
We have to we have to infuse 3% NS, sir.
Before that,
how to calculate?
Calculate body total body.
Before giving 3% saline, should there be any other treatment instituted?
Lasix, sir.
This is dilutional hyponatremia, isn't it?
Yes.
So remove the excess fluid from the body. Okay.
Okay,
so Lasix is the first primary treatment. So how much of Lasix you will give?
20 to 40 mg Lasix will give, sir.
If the patient has not been taking Lasix earlier, okay, but if the patient has been already taking Lasix 40 milligrams every day morning, then what will you do? 10
to 20 mg Lasix.
You have to double the dose. Okay?
Double the dose.
So
Okay.
if the patient is not taking any diuretic earlier, you can give 40 milligrams of Lasix. But if the patient has already been taking Lasix as a routine treatment, Then you have to
80.
double the dose and give 80 milligram or even 130 milligrams to first remove the excess water from the body. Then you start correcting the sodium by giving 3%. Any other alternate to 3% sodium chloride?
Mannitol.
Mannitol is considered as a treatment for this. It's mainly for as a diuretic to reduce the cerebral edema, just like acids. But in this case, giving mannitol will it not aggravate the first? It will only increase the circulating volume.
Okay, sir. Nitrous inhibitor, sir.
Sodium bicarbonate. Have you
Sodium bicarbonate.
heard of treating the hyponatremia with sodium bicarbonate?
No, sir.
No. It is also recommended.
Okay, sir.
That is for lower, not this severe, 114, it may not respond well, but if the
Okay, sir.
sodium value is between 120 and 130, that can be easily corrected with bolus doses of, that is as an infusion, you can give 75 to 100 ml of sodium bicarbonate and correct the hyponatremia much faster without any fear of giving the complications of 3% sodium chloride. Okay?
Okay, sir.
Right. So what are the risks in giving large volumes of 3% sodium chloride? How will it be administered? How do you have to, what are the precautions you have to take while administering 3% sodium called hypertonic saline?
We have to check every hourly, sir, after giving a transfusion of
While giving, what are all the precautions you have to follow? How much you can give safely per hour?
less than 100 ml per hour. You have to transfuse.
Not 100 ml is the safe limit. Okay, 100
Okay,
or
okay.
less than 100. Okay, not more than 100 ml per hour, and it should be done through a central line or a peripheral line.
Central line, sir.
Preferably central line. All irritant drugs or hypertonic drugs are better given through a central line rather than a peripheral line. And should the patient's heart rate or ECG be monitored?
Yes, sir. We have to monitor.
Yes, ECG monitoring also should be done. So these are the three precautions you have to take. One is it should not exceed 100 ml per hour, preferably given via a central line and under constant ECG monitoring. These are the 3 points you have to say whenever you are talking about 3% sodium chloride. Earlier, one dreaded complication of fast infusion of 3% saline is considered. What is that? The neurological system.
Demyelinating syndrome, sir.
Very good.
Pontine demyelination syndrome.
Spontaneous demyelination. Or it's also called because this is also a hypertonic fluid, it will retain fluid inside and especially in the nervous system and cause disruption of the neural coverings. Okay, myelin sheath disruption. So that is called spontaneous demyelination. But of late, all the papers say that it is not true, not happening if you rapidly administer 3% saline. So the current critical care textbooks say that 3% saline can be given at a rapid rate also.
Yes, sir.
Right. So that is the treatment for TURP syndrome. And supposing this is not happening, after 45 minutes, suddenly patient complains of excruciating pain in the lower abdomen. What would be the reason?
Maybe intraperitoneal bladder
perforation has happened and fluid has started going into the peritoneal cavity. Okay?
Yes, sir.
Right. So what is the treatment for that? Supposing he's a new surgeon and he has perforated the bladder.
Suprapubic catheterization and
no, the diagnosis has been made. There's a fullness in the suprapubic region. Patient is complaining of pain. Bladder irrigating fluid is not returning in the same volume. Lesser fluid is coming out whenever he tries to empty the bladder.
Yes,
So
sir.
all these things confirm that there is a perforation. So if there is a
Yes.
perforation, what is the further step with the management?
Antibiotic coverage should be there, sir, with urethral catheter drainage and repair
Will
of
there be any
perforation.
abdominal laparotomy should be done or not? That is the idea of asking this question. So you have to open the abdomen and close the rent, or can it be just left alone?
No, sir, we have to open, if it is major perforation, we have to open exploration and we have to repair of perforation, sir.
So if there is a suspicion of intraperitoneal extravasation, better to open and identify the pierced portion and then try to close all the rent and leave the catheter for longer duration for completing the healing. Okay?
Okay,
So
sir.
that is another important intraoperative complication. So how do you calculate the blood loss in TURP?
Actually, 7 to 20 ml per gram of resect per gram blood loss should is 7 to 20 ml per gram of resected tissue will be there, sir. Blood loss is calculated by formula, sir. Hemoglobin of the irrigating fluid into amount of the fluid irrigating fluid by volume of fluid by patient's hemoglobin, sir.
Hematocrit of the irrigating fluid multiplied by the volume of the irrigating fluid divided by the patient's initial hematocrit multiplied by ECF minus ECF is the formula. Okay?
Okay, sir.
Extracellular fluid. So that will give you a rough idea about what are the reasons for continued bleeding in TURP surgery. Supposing every cut there is a bleed, and after coagulation also there is continuous bleeding. And after surgery also there is a bleed continuing. The urine draining is not clear, it is reddish. What are the reasons for the continued bleeding in TURP surgery?
Any coagulation?
This patient might have been having the
Any anticoagulants?
agents properly not stopped in a time, and altered coagulation profile is one reason. Even
Yes,
in
sir.
non-antiplatelet taking patients, is there a chance that bleeding can happen? So what is the reason for that?
Post-state release some thromboplastins
Ah,
which cause DIC and
urokinase.
yes, sir,
Urine
urokinase and
release,
plasminogen,
local
fibrinolytic agents.
release of urokinase from the prostatic bed or prostatic tissue. Okay? So if supposing that is the suspicion, what drug will help?
Tranexamic acid
Tranexamic acid or
and
what is IACA? Epsilon and
etamino.
Okay, so antifibrinolytic agents will be helping to control this particular condition. Okay,
Okay.
so post-operatively, surgery went on well, everything has all right. Patient's bladder has been catheterized with what type of Foley catheter they use for TURP surgery? Is the regular Foley that you use for draining the bladder in all patients, or a different type of Foley catheter?
Double lumen catheter, sir.
Triple lumen, not double lumen is what you use. One for drainage, one for inflating the balloon. That is the double lumen Foley catheter, normally used for all patients. But for TURP patients, we use what is called a triple lumen catheter. What is the role of the third lumen?
For irrigating the bladder.
For irrigation and removal of any clots or any accumulated debris. Okay. So triple lumen catheter will be passed, and how much of saline will be injected into the bulb, Foley bulb?
15 to 20 ml.
40 ml will be injected. Okay, a Foley catheter is normal case you inject 15-20 ml for even a normal patient when you want to catheterize the bladder. But for TURP patients, the surgeons usually use 40 ml to inflate the balloon and pull the balloon to the
Tip.
towards the urethra and strap it to the thigh, isn't it?
Okay.
So
Yes, sir.
why is it done? Is the
Uh,
purpose of pulling the traction of the Foley and strapping it onto the thigh.
to prevent bleeding from the
It is
prostate.
like a tamponade, pressure. So the
Tamper. Yes, sir.
inflated balloon will press on the
Up.
prostatic bed and collapse all the veins because it's more of a venous ooze. So it will
Yes.
press on the veins and then try to prevent any further bleeding. So this is like a compression. Yeah.
Okay.
What is the complication that can or the discomfort that can produce by this traction on the Foley post-operatively? Can patients complain of pain or
Urethral pain.
irritation? Why it
Yes,
is
sir.
so irritable? Which is the area where this balloon is kept? What is the anatomical name for that area where this balloon is?
Prostate urethra.
It is called the trigone area.
Area.
Okay.
Okay. Sir.
What are the boundaries of this trigone?
Two urethral
Two urethric
orifice.
orifices and the urethral
And,
orifice. Okay, they
yes, sir.
make a triangle. So that is why it's called the trigone. And this trigone area is the most sensitive area of the bladder. So this
Okay.
pressure, when it start, once the local anesthetic effect or the spinal effect wears off, patient may start feeling this pain or the irritation at the trigonal area, which will make them restless. So addition of your buprenorphine or your fentanyl will help in reducing this complication. Okay.
Okay. Okay, sir.
What about the temperature problem in these cases?
Due to continuous irrigation, there will be high chance of hypothermia, sir.
Very good. So why hypothermia should not be allowed to happen in these patients?
Elderly patient is more prone to hypothermia because their thermoregulatory center is altered, sir. And there is a chance of bleeding, sir. High risk of bleeding if hypothermia persists.
More than the bleeding, what is the important thing? How will the patient try to compensate for the hypothermia?
Shivering, sir.
Shivering. So when there is
Leads
shivering,
to
what will it
pacemaker
do?
dysfunction. Leads to pacemaker dysfunctions.
Pacemaker dysfunction, but more than that, whenever there is a shivering, what will happen to the oxygen requirement?
Increased oxygen requirements, sir.
Oxygen requirement, 200% increase will happen. So patient will have hypoxia, and that may also cause a worsen any underlying cardiac pathology. Okay. So
Okay,
it
sir.
should not allow the patient to develop hypothermia. And of course, other problems of hypothermia is continued bleeding or alteration coagulation profile, delayed wound healing, septicemia. All these things are other problems of hypothermia. Okay.
Okay, sir.
Right. Very good. So, Dr. Vasanthi?
Sir, blindness, sir.
Irrigating fluids. That is another
Yes, sir.
problem. So, what are the common irrigating fluids they use?
NS, glycine, mannitol.
What percentage of glycine they use?
1.5%.
1.5% glycine is commonly used. What are the complications of using glycine?
Retinal damage, sir. And post-operative visual loss.
What is exactly glycine?
It causes hyperammonemia and glycine is a inhibited neurotransmitter, sir.
Neurotransmitter, inhibitory
Exactly.
neurotransmitter. Okay, just like your GABA,
Yes.
aminoglycine. Glycine is also another
Inhibited neurotransmitter.
transmitter, so it can cause all these problems.
Sir, a visual impairment.
Okay.
First up.
Okay.
Due to glycine.
Right.
Yes, sir.
So
Due to glycine.
once again, I will just Vasni, கொஞ்சம் continue பண்ணுங்க. Grandson got hurt and he come inside. I'll just come. Please carry on.
Sure, sir. No problem, sir. Okay. So, so you said it's a inhibitory neurotransmitter, isn't it?
Yes, ma'am.
The glycine, yeah. So, and we're using 1.5%. So, what is the maximum amount of glycine which is allowed, which is you can allow them to use?
Sorry, ma'am. No idea, ma'am.
How much? No. How much of glycine? How much of the one bottle of glycine that they use for irrigation? How much does it contain?
5 liters.
Hmm. Look
5
it up,
liters.
okay?
Okay, ma'am.
5 liters. 5 liters.
Okay, ma'am.
You've seen it?
Yes, ma'am.
Okay. What is a recent one? What is a recent solution that they use for irrigation? And why?
Glycine.
What are all the irrigating fluids? What is the advantage, disadvantage?
We can NS fluids. We can use NS, glycine, mannitol, distilled water, and 16.
Cytosol. There's something called cytosol. No, what is that?
This is cytosol.
What is that? What does it contain? Why is it supposed to be better than glycine? Okay. And nowadays, nobody does. I mean, like TURP itself is becoming much lower, much lesser. So what they're using is they're using robotics, isn't it?
Yes, ma'am.
Robotic removal of the prostate is the maximum thing that is being done, isn't it? So
Yes,
what are
ma'am.
the problems with robotic removal of the prostate? Robotic prostatectomy. How is it different from our regular TURP?
It requires no. It requires general anesthesia, ma'am.
Why?
Due to position, difficulty for positioning, and
What position is used? That's how we're coming. What position is used when you're doing a robotic prostatectomy? This is what will be asked nowadays, because TURP is becoming lesser and lesser, and people are getting more into robotic removal, is it? Robotic prostatectomy.
yes,
So what
ma'am.
are the advantages of robotic? What are the disadvantages of robotic?
The class represent.
Anybody can answer. If it's not you, anybody can answer. No problem. Anybody else?
Advantage and
Yeah.
disadvantage of robotic surgery.
Can anybody else answer, please?
Ma'am, good evening, ma'am.
Yeah.
Ma'am, in robotic prostatic surgery, ma'am, steep positions will be required, I guess, generally,
Yes.
and docking and undocking takes time after
Yes.
it has been done. So if at all emergency comes, then it will be difficult
Intubation.
to it will be a
Exactly.
difficult.
Exactly. Yeah. So what he said in the beginning, that usually general anesthesia is what is being given, is correct. And
Yes,
when I'm
ma'am.
asking you why, this is the answer I'm expecting. First of all, docking and people are, some people are experts at robotic, and many people are still learning. So the process of docking and unlocking and delocking, whatever they're doing, is going to take time. And the position is going to be what position?
Ma'am, steep head down position,
Steep Trendelenburg position. Yes. What is the disadvantage of that position?
The head down.
For us.
Again, ma'am, respiratory and cardiovascular and respiratory compromise means decrease FRC.
Just like any
yes,
Trendelenburg position, you'll have all those complications. That is okay. In addition,
Patient
Accessibility will not be.
what?
Patient accessibility will be limited.
Access. Yeah, for us it'll be access to the patients. But head end is okay. Airway management will be okay because they're not going to come anywhere near by here. Okay, that's not an issue. What about bleeding? What is the advantage of robotic surgery over regular manual surgeon's surgery? Generally.
Strict precision, ma'am. It is a precise surgery.
Precision. Yes. How do you get that precision?
And, ma'am,
Precision,
it's
yes. How do
it's
you get
been
that
done.
precision?
It's
Now,
been done by a machine, so ma'am, manual errors, human errors are avoided, like tremors and all, leading to unnecessary
no.
bleeding.
The surgeon only will be doing it. Oh,
Yes, ma'am.
the
Yes, ma'am.
surgeon's tremor is also filtered by the
Yes,
robo.
ma'am.
That is the main thing. If you have a surgeon who's got tremors in his hands and he's handling the robotics, the robot, when it comes to from the robo, the tremors will be much lesser and the functionality of that surgeon itself will improve. Okay, that's what. Next, that's the precision. And what else can you? What else can you do? Can you do a 3D or 2D, or how is it? How can you visualize the organ, whichever you're operating?
So, Arun.
3D visualization.
Yeah, you can visualize. The visualization of the organ that you're operating will be much better than with the regular. Okay. All right. Okay. Next.
நான் என்ன பண்ணேன்?
Next. What about the bleeding?
Difficult to control bleeding in
No, the bleeding itself is much, much lesser. When you do robotic surgery, the bleeding is much lesser than when you're doing a regular TURP. So that is why this is gaining more popularity than the regular TURP. Okay. Have you all heard about open prostatectomy? Have you ever seen it?
no, ma'am.
No. Okay. Earlier days, they used to do something called an open prostatectomy for some where the size of the prostate has become much lesser, much bigger than I think when you're not able to do it in the TUR. When it's not doing a transurethral resection, then they do an open. When they do an open, like I said, tranexamic acid is always given, or you can give epsilon aminocaproic acid, that is ECA. Okay. Both of them are anti-fibrinolytic agents. So these are things which you must keep in mind when you do a prostate surgery. And hyponatremia, you were talking about hyponatremia at that time. You must know how to calculate the amount of sodium that you have to give for the patient. Of course, you give Lasix, you get the volume down, as long as the patient's hemodynamics are normal. When you give diuretics, you must make sure that the patient does not have a drop in blood pressure. It's a very important parameter that you have to measure when you're giving diuretics. So if the blood pressure is normal and then you're giving diuretics and then you check the sodium levels and you found it still very low, what are the levels at what happens to the body of hyponatremia? What happens at 130 to 115? What happens below that? There are rules, no?
Yes, ma'am.
What happens at each? Yeah, what is that?
At 120 milliequivalents, CNA disturbance will be there, ma'am. Confusion, restlessness, and in ECG findings like prolonged QRS widening will be there. At level 115, somnolence, nausea features will be there, ma'am. In ECG findings, along with the wide QRS complexes, ST segment elevation will be seen, ma'am. At level of 110 milliequivalents, seizures, coma, with the ECG findings like ventricular tachycardia, ventricular fibrillations will be seen.
Yeah, by then they'll go for arrest. Okay, that
Yes,
level will
arrest.
just go for they'll go for arrest. Okay. So what is do you start treating it only when it comes down to 120, or do you start treating it at a higher level? Suppose it is 130. Suppose it is 130. Okay, normal levels is 140, 145. It comes to 130. Should you treat it immediately, or should you wait, or what else can you do? In a patient with TUR, I'm not talking about anything else.
Okay,
In a patient with TUR, because hyponatremia, if you take into consideration, so many varieties of hyponatremia are there, isn't it?
yes, ma'am.
Yeah. Have you heard about the types of hyponatremia?
Yes, ma'am. You
What are the
volemic
types of hyponatremia?
euvolemic hyponatremia, hypovolemic hyponatremia, and hypervolemic hyponatremia.
Correct. So what is this?
Hypovolemic, hypervolemic hyponatremia.
Hypervolemic. This is hypervolemic hyponatremia. Right. So as I said at the beginning, you have to bring the fluid out. Give them Lasix, bring the fluid out. Make sure that the hemodynamics are normal. It is done. Only after that you will start correcting. Okay. So just because you have found one value of 130, but if it is correlating with the clinical findings, like the patient becoming very restless and the patient is not responding, things like that, then you can start treatment. If the clinical correlation is not there and you have just found one value of slightly reduced sodium levels, you must correct the volume status, recheck the sodium values, and only then correct the hyponatremia. Okay, so that's a very important aspect that you have to remember. So,
Okay.
so what are the problems of lithotomy position? This is an old man, isn't it? This is an
Yes,
old
ma'am.
man who's coming for procedure. So what are the problems of lithotomy position?
More chance of fractures, ma'am, hip fractures, and
Fracture.
ma'am,
Why?
neuro, ma'am.
What? Why should there be a fracture? Lithotomy position. Okay, so there's a question, isn't it? There's a question in your theory paper also.
Yes,
The
ma'am.
changes that happen to the body systems like the CVS, RS, the other systems and all that due to
Okay.
various positioning, right?
Yes,
You have
ma'am.
a left lateral, right lateral, prone position,
Yes,
sitting
ma'am.
position, beach chair position. Then you have
Yes.
lithotomy position, right?
Yes, ma'am.
So if you have a lithotomy position, what are the changes that happen to the person's body? What will happen to the venous return? What will happen to the cardiac output? What will happen to the diaphragm? What will happen to the respiration? What will happen to the FRC? What will happen to the vital capacity?
Increase.
Lithotomy position. Hmm.
Yes, ma'am. There will be increase in venous return, ma'am. Lithotomy position. There are
Hmm.
three types of lithotomy, ma'am: high level, low level, and very high level.
Hmm.
Increase in venous return will be there, ma'am. Increase in cardiac
Okay.
output. In a very high level, in very high level lithotomy position, there will be chance of decrease FRC, ma'am. Mm,
In TURP, what level lithotomy do we do normally?
low level
Low
position.
level. Yeah, it is not like a steep lithotomy. It is not like that, right?
Yes,
Okay.
ma'am.
Hmm. Hmm. In OG procedures and all that, or in gastroenterology procedures where you have to do APR and things like that, then you will require that kind of a lithotomy. For prostate, you don't require a very high lithotomy. It's a low level, right?
Yes, ma'am.
So the complications are not too much because of the positioning. Only
Yes,
thing, the pressure effects and all that, because it's an old man, he
yes,
can
ma'am.
have osteoporosis. You said fracture.
Yes.
So I'm asking you why fracture. You should say there is a chance of osteoporosis. So we must
Okay.
handle the patient very carefully. So
Okay.
hence, because of osteoporosis, the patient can develop fractures if you are handling the patients very roughly. Okay.
Okay. Okay, ma'am.
So if somebody asks you why, you must be able to answer the reason for whatever you're talking about. That's all. It's as simple as that. Just put your mind to it. It's very easy to answer. All right. Then what did you say that you're doing? Pacemaker, everything was covered.
Yes, ma'am.
Blood loss. Yeah. What is a transfusion trigger? Suppose the patient's preoperative hemoglobin has been 13 grams.
Yes, ma'am.
And you have calculated that the volume loss or the blood loss has been about 1 liter for
Yes,
this
ma'am.
patient. And postoperatively, he's continuing to ooze. So
Okay.
how will you now transfuse this patient? When will you think of giving a transfusion to this patient?
Hemoglobin 8 is a transfusion trigger, ma'am, for this patient.
So how much should be the hemoglobin for you to start transfusion?
8 gram percentage, ma'am.
8 grams. Okay. Yeah, 8 grams is that you have to give anyway, right?
Yes, ma'am.
Suppose it is 9 grams. Suppose it is 9 grams.
Okay, ma'am.
But he's continuing to ooze. Would you still like to give transfusion?
No, ma'am. We have to correct any coagulation disorders due to hypervolemia, chance of coagulopathy.
You have to make sure that there is no other cause of his
Yes, ma'am.
increased bleeding and the anemia that the patient has developed before you
Okay.
give the transfusion. Just like that, if the patient is going on bleeding and you keep on giving RBCs, there is no point, isn't it?
Yes,
If the
ma'am.
patient has got a coagulation disorder. If the
Yes.
patient has got a coagulation disorder, correct that.
That-
And in the meantime, like how will you correct any coagulation disorder? For example, if the patient is going for DIC,
Yes.
how will you manage? What
FF,
investigation will you do?
FFP, ma'am.
Hmm.
FFP
FFP
are,
can be given. Hmm.
yes,
Hmm.
ma'am.
Okay,
And
then.
tranexamic acid we can give for bleeding stoppage, ma'am.
Okay.
What exactly happens in DIC, Sai?
Uh, Consumption coagulopathy, sir.
Very good. Okay. What do you
Exactly.
understand by that?
Platelets are used, are consumed fastly, sir. There will be both thrombotic and hemorrhagic events will be there, sir, in DIC.
Hmm. So the term disseminated intravascular coagulation. So there is a initial process is one of coagulation. Once
sir.
all the clotting factors are used up for the intravascular coagulation, then there is a lack of clotting factors which results in bleeding from wherever sites where there is a disruption in the vascular tree, isn't it?
Yes, sir.
So initially it is a intravascular thrombosis happening. Later on only it starts bleeding from whichever side there is an injury or a disruption in the vascular wall. So it is a paradoxical situation with an initial excess clot formation, later on resulting in DIC. So during the early stages of clot formation, you want to prevent that. So you have to
Okay.
give very judicious doses of heparin to prevent that clot formation. But later on, when the bleeding starts occurring, nowadays you insist on the fibrinogen level because that is the one which is ultimately used up and that is the one which has to form the clot. So,
D-dimer and
what level of fibrinogen you want to have?
Sir,
What is the normal level of fibrinogen that you should have in your blood for normal?
400 to 600 mg.
400 minimum.
Sir, minimum 400, sir.
Are you sure?
100.
150 to 250 milligram per deciliter.
Okay, sir.
That is the value for fibrinogen. So when it comes to less than that, it's better to give fibrinogen concentrate rather than FFP. Okay.
Okay, sir.
So this is the mode of treatment. Early stages of suspected DAC. So what is the best method to identify whether the patient is going in for DIC or not? What investigation or point of care testing will tell you that?
Take this, sir. The thromboelastography.
Thromboelastography gives the picture of both the hypercoagulable state initially and also the bleeding state. You will get two different graphs. Initial stages, you will get the hypercoagulable state. Later stages, you will get the
Bleeding.
state. So the graph that you get in thromboelastogram will clearly tell you whether the patient is in the early phase of DIC or in the late phase of DIC. Accordingly, you have to treat. Okay.
Okay, sir.
Okay. I don't know how to show the PPT now. Ramarshi, shall I just log in?
Sir, yes, please, sir.
Disk and then try to
Thank you, sir.
show the PPT?